and then ask, how do you pray? You know, finding out their cultural need, finding out their denomination need, finding out how I would need to phrase my prayer to fit that as best I can. I'm not asking any of you ministers to cross a line of faith to where you would go, I don't do that. What if they were Islamic and you go, well, I don't pray Islamic prayers? I'm not asking you to. What if they were Jewish and you go, well, I just cannot pray or not pray in the name of Jesus? I'm not asking. I'm saying be a minister in their place for them. And if you can't connect, call someone who can. So I'm not asking you to lose your faith or be wishy-washy or straddle the fence where you go, well, I can't do that. You know, as a minister, I just can't go that far. Okay? Well, I'm not asking you to give up your denomination or your faith or your traditions or the way you do things. I'm asking you to connect with them, and if you can't, refer. That way they get their needs met. Okay? So you can honor your faith traditions and go, I can't go that far. There's always a certain chain we're kind of tethered to where we can go, I can go this far, Larry, but no farther than that. Okay, fine. So I'm not asking you to give up any of your faith traditions to be able to be a generic minister in the hospital. Any questions with that? 'Cause that's usually the biggest hurdle that local ministers have. What are you asking me to do and be? How far are you asking me to go? As far as you're comfortable. And then beyond that, refer that to their type of minister who can do that. Let's say we're going to see the deceased. Now, this is not a picture of actual deceased. This is a mannequin, so it's legal. But let's picture you were going in, that you were sitting in the waiting room before with the family, and you've gotten in contact with the nurse that it's okay to go in and see the deceased, and you're taking the family in. The first thing I would be aware of is standard precaution, washing hands. Just because the patient has died doesn't change their infection. If they had MRSA, C. diff, staph infection, any and everything, if they had it before death, they have it after death. No, this is what I see family members doing. Although they gowned up, gloved up, and masked up before the death, after it, they're kissing all over them. And I'm going, well, wait, honey, wait. You know, they forget, and they don't care. So if I'm the only one of the hospital team that's there, I go, wait, let's put a gown on, let's put our gloves on, just as before. And they go, oh yeah, I forgot, you know, because they're going to catch something, you know, if they don't be careful. So we help them guard it, and you too. You come in the same way, you model that. You see that sign on the door that says gloves or gown or mask, we're the same thing as you come in. Make sure the patient is covered properly. Nurses just about 99.9% of the time take care of that. But I've seen where the team was in trauma that the team didn't necessarily see something. I've gone into like motorcycle accident victims where the one arm's totally severed off and you could see down in the chest cavity and they didn't have it covered. Now, I think the nurse had a motive. The motive was, do you understand why we couldn't save him? Okay? There was a motive there. She was trying to tell a story, but it was a shocking story. You know, so after, you know, I said, is the patient ready to be seen? Yes, and we walk in, oh my. You know, of course I don't do that, but I'm thinking to myself, oh wow, then I'm covering up, okay? So the question may be at the nurse's station, can we go see Mr. Jones now? Is he ready to be seen? And there may be situations where, no, we need to wait a few minutes, we need to clean up the room, we need to change something on the bed, or there may be soiled linen, there may be bloody linen, or whatever the trauma may have been. So there may be something they need to prepare first. Then ask the nurses to deal with secretions as they pull out IVs, especially in the trauma room like an ER. There may be secretions that are going on with car accidents, things like that. Something may start oozing or bleeding while you're there, and you might need to go out and ask the nurse to come in and take care of that. Now, being discreet as I am sometimes, and I'm not asking you to play nurse, but there's sometimes that I go get a glove and I take a bed sheet with my glove and I put pressure on the secretion and nobody ever knows the difference. So it's not a big deal. I'm not asking you to do that. I'm just saying there are times when you might take care of things and you don't need to call anyone. But other people are like, no, not me. Well, I'm not asking you to, okay? I'm not saying that's your role or your job. But just being comfortable with the setting, there are some things that I've done that take care of that. The intubation tube, if the patient was intubated, there's a tube down their throat that they were using to breathe for them, either by the ambu bag or by the ventilator machine. When they get done with the code, there are some times when, you call yours a medical examiner or
That's
a coroner. There are times when they say, no, we can't take that tube out yet.
Correct.
Until certain things happen or certain situations,
Can't remove any lines.
maybe right after surgery or maybe a trauma, something like that. So that maybe they're making the decision when that comes out. So you may go in and say, is the patient ready to be seen? You walk in, you see a tube in their throat. And you think, oh, nurse, you forgot about that. But they're quite aware of that. They may not be able to take that out yet. So this one question I asked before I go in, will there be the breathing tube still in the mouth? Should I prepare them for that? Yes, that will still be there. So I go, when we go in, we're going to still see that tube in the mouth. The medical examiner hasn't said we can take it out yet. We will do it as soon as we can. Just want you to know, do you want to go see now, or do you want to wait till that gets taken out? Now that could be 30 minutes or an hour, you know. No, we want to go in now. Just want to let you know that's what you're going to see. So you can go in there and you can kind of notice what's going to be going on around the room before you walk in. What I like to do, I like to walk in by myself and visually see the room and then bring the family in. That way I know what's going on before I walk in there, what I'm going to see. There are times when the patient's eyes are still open or have come back open again. Not asking that you do this, but if you wanted to, you could put on a glove and close their eyes. If you want a nurse to do that, you can. But if you were to just put gentle pressure on their eyelids for a minute or so, they usually stay closed. The jaw is usually a much greater, harder issue, because if they've been intubated and they have died and it's been a few minutes or hours and rigor mortis sets in, then the jaw is hard to close. So they may be this, oh honey, shut your mouth, you know, kind of thing, and it won't stay closed. Beyond putting a pillow behind their head or putting something rolled up under their chin, it's not going to help. So I just go, well, that's just the way his body is. Remember the tube that was down there, something like that. Just kind of let them understand the picture, what's going on. Some get really grieved over that, and others don't seem to bother at all. If it's a trauma situation in the ER, there may be belongings that came in with the patient that you would let the nurse, again, it's my role sometime, I've gotten things down in back pockets, front pockets, and all around, and washed those off, cleaned them up, and given those to the family members. We're not asking you to do that. We're just saying there may be times when in a trauma come to the ER that they came in with what they were wearing and they have all kind of things in their pockets. The nurses will be taking care of that for you to gather those belongings to give to the family members as they leave. Now sitting with the family, just say the death has occurred, they've already gone in to see the deceased, and they're just hanging around. Part of the question is, well, when do I go? Is there something else I need to sign? Anything else I need to do? And they don't want to go home and leave them there. They're going, you're asking me, you know, I thought we were going to bring him home tomorrow, and you want me to leave him there? And the funeral home's coming? I can't leave him. This emotional impact of I'm going home without them. So they will make that decision when they get ready of it's time. Usually a family member makes that for you by saying, Mom, come on, we need to go. Nothing more we can do here. Sometime a family member will suggest that, and then they go, you're right, I guess we stayed long enough. If you want to go in one more time to see him, you can, but really nothing more we can do here. And then they make that decision. But there are times as they're hanging around, whether through the code or right after the code, waiting to get in,